Let me get started. My name is Steve Davis. I'm the president and CEO of PATH. And for those of you who don't know us, we are one of the leaders in global health innovation. Been around about 40 years, working in over 70 countries. We focus on women, and we really are focused on health equity issues and health inequity, or addressing health inequity, but particularly on the most vulnerable populations, which of course are women and children around the world. And we're really all about leading and working on innovation in health in a lot of areas, vaccines, diagnostics, tools and devices, drugs, as well as a lot of system and service innovation. But we really believe deeply in the power of innovation to transform and bend the curve on some of the challenges we have to get to better equality in health. And so during the working group sessions at this great forum, we've actually explored a number of ideas in health, both in terms of how do we innovate, how do we get good ideas, how do we scale things up, what are some of the challenges. So today we want to sort of take that forward in a plenary to talk more deeply and extensively about some of those challenges. And so no one is probably as well equipped to talk about the opportunities and the challenges to innovate and to really rethink system strengthening around the world as much as our speaker, Tom Frieden, who's going to start us now. It's a pleasure to introduce Tom, who's been at the forefront of the conversation of health system strengthening for quite some time. He's the director of the Center of Disease Control and Prevention, and he's really, since 2009, expanded the services of CDC to protect people from health threats, preventing foodborne and healthcare-associated infections, helping Americans quit smoking, and extending life-saving treatment and disease prevention in more than 50 countries. Unfortunately, Dr. Frieden's schedule is very busy, and he wasn't able to attend in real time, but as someone who maybe a bit more contrary to the panelists last night, who is a true powerful believer in the power of technology and its transformative and opportunities, we can have this conversation virtually. So Tom, welcome, and thanks for joining us.
It's great to be with you, Steve.
So maybe, Tom, we'll just kick it off, and we'll go from there. But I want to the focus. Let's start with Ebola. It's on the tip of everyone's tongue. It's still. I've just been in probably 5 meetings in D.C. where you can't go for 10 minutes without that conversation, even though we've got many health issues to worry about around the world. But Tom, tell us from your perspective. What are the big lessons from Ebola that we need to think about as we talk to particularly a group of committed philanthropists about how and what needs to be done next?
There are 2 major lessons from my perspective. The first is that every country, everywhere in the world, needs to have much stronger systems to find, stop, and prevent health threats. Those systems exist in some places. If they had existed in West Africa, we could have avoided an enormous amount of the terrible tragedy of the past year. The second main lesson is that when those national systems are overwhelmed, we need a stronger international ability to surge in and support countries for disease control. To my mind, those are the main 2 lessons. Now, what's the implication for philanthropy from each of those? Let's take them one by one. First, what we call global health security is strengthening something called the international health regulations. Fundamentally, it's about finding and stopping health threats where they emerge, when they emerge. That's always going to be the most efficient. That's always going to be the cheapest. It's always going to be the best way to do it, but we've got to do it everywhere, because anywhere there's a weak link, anywhere there's a blind spot, our vulnerability globally increases. To do that, you need a variety of things, and different philanthropies can play very important roles in those different things. I'll talk about 4, if you will. First is, the core here is find, stop, prevent. You remember those 3 things, you remember what we have to do around the world. So find, that might be anything from funding novel diagnostics to using new technology to get reporting done, stop, that means rapid response capacity, and that might mean training disease detectives and public health professionals. And prevent, that might mean improving vaccination programs. We have Rotary and Gavi and other philanthropies that have done a lot in that area. So for building national capacities in each of those three specific areas, there are specific things that can be plugged in. But I want to add a broader issue. We talk about health and health system strengthening, but we don't talk often enough about strengthening the public health systems. Public health is the best buy. We have delivered most of the life expectancy gains globally in the U.S. through public health measures, not healthcare measures. And yet, because public health doesn't have an interest group, because it doesn't employ large numbers of people, because it doesn't provide curative services to the decision makers in countries, it tends to be neglected. Ebola and our post-Ebola moment is the moment for global public health. And part of what global philanthropy can do is advocate for focus on these areas and show that when they're invested in, they make a difference. That's on the national capacity side. On the global capacity side, there are a lot of discussions on what can be done, but fundamentally, we need the ability to rapidly move in with a broad range of skills, including some of the things that we didn't have in ample number in Ebola, like French-speaking skills or anthropological skills or clinical skills or logistic skills. And we have to be able to do that very quickly. One of the things that we learned very painfully from Ebola is the supreme importance of speed. In October, November, we began implementing a program in Liberia called RITE, Rapid Isolation and Treatment of Ebola, RITE. That program was able to cut the time of outbreaks in half and double survival rates and show us that if we got in days, we could limit the number of cases to a handful or a dozen or two. If we got in weeks or months, it could be hundreds or thousands. So we need that speed, and philanthropy is always going to be crucially important in delivering speed. We were able to work with the CDC Foundation, created by Congress, on the Ebola response, and their input was enormous in allowing us to do things much faster that we wouldn't have been able to do otherwise. So speed is always important, advocacy is always important, and focusing on things that are the general good and not a good of one particular interest group or sector, these are core roles for philanthropy and global health, and I think Ebola really demonstrated that.
Thanks. It's great to get that sort of broader landscape and those points. I guess I'm curious, maybe you can unpack a bit for this audience, which are many of whom are not global health experts, and I'm not even sure those of us that or maybe sort of that can know. We hear a lot of words right now. Preparedness, and lots of focus on what do we need to do to prepare for the next epidemic, and a lot of focus there. There's a lot of focus on health systems, strengthening or rebuilding health systems, although the question is, are we rebuilding or building? And that's a fairly jargonish word that I think we don't really understand. And then of course there's a lot of work on what's sort of routine versus needs to be done more in a routine manner versus in a either campaign or a crisis manner. Can you help kind of give us a little bit of the 101 on that? So where do you think philanthropists should be thinking around those three different buckets of activities?
So first off, perhaps the most important lesson from the emergencies we've dealt with over the past 15 years, going back to 9/11 and anthrax, is that what works best in an emergency is not an emergency system that you break the glass on and then cut the shrink wrap and study in an emergency. It's an everyday system that's robust and resilient and can be scaled up. That is really a core concept, and that means that we have to do things that strengthen those routine systems in the public sector, in the private for-profit sector, in the philanthropic sector, and figure out ways that what we do every day can be scaled up in an emergency. For health system strengthening, there are a broad range of things that need to be done in countries to strengthen training, payment, information systems, so that the care that people get is good quality, timely, respectful, and improved. We continuously improving. There are systems that work well in global health, and those systems all share certain criteria. They have a limited package of interventions. They're not scattershot. They find a few things to do, and they do them well. They have an information system that feeds back in real time whether they're succeeding or failing so that they can fix it. And they're committed to continuous innovation. One of the best examples of this is smallpox eradication. That was something that the World Health Organization, CDC, did. And when we look back on it, we may think, oh, they knew what to do, they did it, they got it done. But a wonderful book by Bill Foege called House on Fire describes as it was lived. In fact, they were constantly innovating, thinking of new ways to do things, coming up with a new needle to use, a new way to have meetings, a new way to report things, a new way to get surveillance done. So the most effective programs always have a limited package, a good information system, and a culture of openness and evaluation and innovation. There is sometimes a dichotomy between research evaluation and program, as if they're different. In fact, they have to be united if the research is going to be relevant and the program is going to be effective. And philanthropy can have a critical role in any one of those areas. I encourage groups that ask me and individuals who ask me to find something that they're passionate about, to be strategic about what they invest in, and then, as long as they're confident it's the right thing to do, to stick with it for the long term. These aren't quick wins. These are long-term projects that you may need a decade or two of investment to fix. That doesn't mean we can't make rapid progress. I'll tell you about one project, for example, in Uganda, where building on the PEPFAR program, which has an important private sector component, we were able to put into place, remember the find, stop, prevent mode, put into place a way to pick up specimens from all over the country, have them brought by motorcycle courier to a hub, have them sent by overnight mail to the capital, have them tested at a high-quality, safe lab, and then have the results sent by GSM printer donated by Hewlett-Packard and printed in the local health center so that patients could be treated, but also sent to the emergency operations center. They've used that system in the past couple of years to find and stop outbreaks of meningitis, typhoid, drug resistance, and other things. So you can make rapid progress, but you've got to stick with it for the long term.
That's great. So great advice for a group of people thinking about how to support and help is, be thoughtful, long-term, find your passion. But now I'm going to even push harder, Tom, is like if you were, if that was you've got given the magic wand, and we'll get to actually the allocation that you are actually managing in a minute. But if you were given sort of the magic wand and said, okay, the most disruptive thing that you could be doing in 2015 to shape either the response to Ebola or, more importantly, the needs we have in this sort of in this Ebola or post-Ebola moment, what would it be? Just the one big wish.
I think we need an objective, independent, transparent way of ranking country preparedness. And that would give us a way of holding countries accountable for whether they're protecting their own citizens well, and whether they're a good neighbor in their region, and whether they are potentially going to be able to find and stop a threat that emerges. Something like the Transparency International Corruption Index, but for global health security. This would be transformational, I think, but there are so many areas where there can be so much progress. If your metric, as it is in public health, is how many lives can we save, there are so many areas that are underinvested in.
Yeah. Treatment
of high blood pressure, as an example. The only thing that kills more people than tobacco around the world is high blood pressure. And yet we only have 1 in 6 people with their blood pressure controlled around the world. Micronutrient fortification. Year after year, consensus statement say this is the most cost-effective thing to do, and yet we're still not doing it for so many people around the world. So I think there isn't just one area, but there are many areas that can be transformational.
And is anybody, is anybody trying to get this transparency, the preparedness index moving forward?
There have been discussions. There are delicacies. We're actually pilot testing right now an instrument that would be first a self-assessment by countries and then an independent assessment and then compare them. And we've got a half a dozen countries that have volunteered to do that. There is a series of discussions going on with the World Health Organization to determine to what level they would be able to contribute or participate in that. Countries don't like being ranked. And in honesty, rankings are often not as scientifically rigorous as bandings of a red, yellow, green. But still, to come up with an objective, transparent indicator, and wouldn't it be nice if you're a business thinking about going into country X if you know where the weaknesses are, and if you're a philanthropist wanting to fix something in country Y, you see where the weaknesses are, or a global financial institution, multilateral or bilateral, to think where can I invest and whether I'll be able to see progress.
That's great. That's cool. Then it sounds like the kind of idea that can stimulate people's thinking about, okay, these are not only do we need to invest in voice and advocacy, which you suggested, and also in some sort of targeted programmatic solutions depending on your interest and geography and your capability, but there's these broader kind of super system ideas that need philanthropists. So you know, and to some degree, one could say, well, there seems to be a fair amount of money now laying around for Ebola. Let's back to Ebola a little bit more specifically. One can argue it's either not enough or too much, but forget that point. So what do you think we should do with it? And maybe you can clarify for this group a little bit the particular appropriation that was given to Ebola.
So the administration requested and the Congress granted overall more than $5 billion for not just the response to Ebola, but also to prevent the next Ebola through the global health security agenda. I can speak most specifically to the CDC aspect of that. We have about $1.8 billion. It is a 5-year program. So after 5 years, it's gone. And our threats will not be gone after 5 years. So we can make a lot of progress, but we can't take stuff off the table by then. Within that, there is Ebola-specific effort in West Africa, and then there is the general global health security effort. It does not fully fund the needs for global health security. We want other countries to step up as well, and many are. We have over 40 other countries that have committed to supporting global health security, either through in their own countries or through support to other countries. But there are still really important gaps, and some of those gaps are speed, innovation, advocacy, and then specific areas, either geographically or conceptually, where more is needed.
Great. So you highlighted, sort of shifting a bit away from Ebola and the infectious disease world, highlighted, the concerns about blood pressure. And in fact, I think, and hypertension. And clearly, a lot of us are spending a lot more time beginning to look at real numbers and start saying, wow, we're going to be really good eventually at getting this infectious disease stuff under control, and we're going to all be dying of diabetes, stroke, and other things. And unfortunately, the data is emerging very clearly, not only the overwhelming impact of what we call non-communicable diseases, but in fact, the disproportionate impact it's going to have on the poor. That this is going to be a disease, a set of diseases, is already a set of diseases that is already, the poorest people in the world are by far the most vulnerable, and so this audience might care about. Can you talk a little bit about sort of how you see the NCD work moving forward? What do you think this audience should be thinking about? I mean, why U.S. policy is, as to global health, is not allocating much money toward this yet, and what we should be doing about that?
So first, it's really important to say that infectious diseases are not dead. And Ebola shows us that. TB is still a major killer. Malaria is still a major killer. We have more vaccines to roll out for the communicable and the non-communicable diseases. HIV remains a devastating problem. So it would be a mistake to say, oh, check, we've got the infectious disease handled. Let's move on.
Couldn't agree more. Couldn't agree more.
In fact, they're not unrelated.
Yeah.
So someone who's gone through infectious diseases is more susceptible to the non-communicable diseases, and people who smoke get more TB. People who are obese are more likely to get pneumonia. So there is a tight connection between the two. On the non-communicable disease front, there are some things. First off, we're not going to get major dollars from Congress on this because it's not a threat to the health of the United States people. So this is going to rely on philanthropy. It's going to rely on creativity, going to rely on some partnerships. You have to talk about tobacco first. And I have to give Mike Bloomberg and his foundation tremendous credit. They've invested hundreds of millions of dollars in global tobacco control. The last estimate I saw suggested that the measures which their initiative had promoted will prevent what's already been done, will prevent at least 10 million deaths from tobacco. So we've got a tremendous progress, but tobacco really is public health enemy number one. If we don't take urgent action in this century, more than 1 billion people around the world will be killed by tobacco. That's a number that's so mind-boggling that every single time I say it, I think I must have gotten a digit wrong, but it's actually true. And this is a major fight. The tobacco industry makes huge amounts of money, has enormous political power, pays off politicians. And when I began doing tobacco control, I said, it was really hard fighting tuberculosis because nobody cares about tuberculosis patients. They're the poorest of the poor, and it requires systems that work day in and day out in the most remote areas. But at least in tuberculosis control, we didn't deal with people paying off government officials and marketing their products in sleazy ways and getting youth addicted. So I think when you talk about global non-communicable disease, you have to start with tobacco. It is the number one. Beyond that, in terms of a disease-specific area, I really highlight hypertension. Hypertension is increasing around the world as diets change, as people consume more sodium, as people get less physical activity, as obesity increases, and we can treat it. The treatment of high blood pressure is very effective, and it's driven stroke rates down, heart attack rates down enormously. It's potentially 1 or 2 pills once a day that cost pennies. And the monitoring of high blood pressure is really cheap. A blood pressure cuff can last 20 years, so it's essentially free to monitor, and it can be done by frontline health staff. Doesn't have to be doctors and nurses. So I think this is kind of waiting to be done in the efforts. There also is much more that can be done with micronutrient fortification, as I mentioned. But I think beyond that, there are some broad issues on training, systems, epidemiology. The Bloomberg Foundation, along with the Australian government and the Canadian government, has also done some to strengthen data for health. So we're not flying blind. Quite frankly, a lot of the data that we're using in global health is a bunch of people sitting around a room saying, that number sounds good to me. That's not acceptable. Too many people around the world are born and die with no record of their existence. And that's not okay. People count, and we should count every event so that we can respond to it, so that we can implement programs and see if they're working. And you have an interest in that, whatever program you're doing. You want to know if your program is working. Last thing I'll mention is training in epidemiology. And the Rockefeller Foundation some time back did some excellent programs on public health schools without walls and other programs. We have something called the Field Epidemiology Training Program. It's crucially important, and we train people in all areas of public health. Creating national public health institutions that can do the kind of study and intervention to see where the problems are, what programs are likely to work, whether they're working, how to get them scaled up. that kind of epidemiologic training is incredibly important. And our field epidemiology training program, I think, may be the single most important thing we do in global health. We've trained over 3,000 epidemiologists around the world. It's a 2-year, hands-on, intensively mentored, practical program. 80% of the graduates stay in their country of origin, usually in positions of leadership in public health. And in the Ebola response, I had the privilege of traveling in Liberia in a remote rural area with one of our trainees from Uganda who had come to Liberia to help, and he was stopping Ebola there. And in Guinea, 10 of our graduates from the Democratic Republic of Congo, DRC, are pivotal to our response there. So it's a tremendous capacity and, quite frankly, has been underfunded. And again, it's the kind of thing it's hard to get people to fund. I like to say there are lots of hospitals that have wings named after people who were taken care of there. There is no health department in the world that has a floor named after the people whose heart attacks or infections they prevented.
That's a great one. And that would be we have about a minute left, Tom. So any last thoughts or pieces of advice or insight or questions for this audience?
I guess it's to be ambitious, to think of what can be done with modest or substantial resources that really can be transformative. You want to find leverage areas. And in global health, those leverage areas can literally save millions of lives. Look at what Rotary has done for polio. Without their input, we would not be on the verge of eradication. And look at what different programs have done, whether it's Gates with Gavi or Bloomberg with tobacco. You're talking about millions and millions of people alive today because of philanthropy.
Great. Tom, thank you so much for all you're doing as an amazing public servant and really leading the charge here. And good luck. And thanks so much. Appreciate it.
Thank you, Steve. I look forward to working with you and with the folks in your audience.
Thanks. And I'd encourage people to keep in their seats because we're going to move right into the panel and say goodbye to Tom in Atlanta. So as the panel comes up, I'd like to sort of continue the conversation now, and I'll quickly introduce the folks to my left, although there's an explicit bio in the about each of them. Is that a question or okay? And we really want to pick up on the themes that Dr. Frieden laid out, but it's this broader question of what do we need to do to really get to the root of these two challenges? One of being able to help strengthen and sometimes build and strengthen systems that actually ensure more health equity. And what does that mean from all the various and complicated rubric cube that involves? Everything from tools and systems, but also to community level engagement and participation, to training, to cultural and behavioral incentives. So there's that, and then there's also this sort of parallel and interrelated question of preparedness. So how do we, obviously the more you strengthen, the less the preparedness is different, but we can't keep ignoring the fact that almost every 6 to 12 months, something else hits the global community. And we're scrambling every time to do that. So I'd love to explore both of those things. So what we're going to do is each of us are going to take a few minutes to talk about the perspective we bring to this, very different perspectives. And then we'll open it up for some conversation up here and then conversations with you all. And so I'm going to quickly mention who's sitting here, although you have their bio. Ian Crozier is an infectious disease specialist on the far left, born in Zimbabwe, but immigrated here, but has worked and lived all over the world, has done some remarkable work in Uganda. He's also an Ebola survivor, so he can talk about the front line and both frontline work and frontline experience experience. Love to hear from Ian. And then we'll actually not go in necessarily this order, but Jacob Gayle is the Vice President of Medtronic Philanthropy, an incredible career in both international diplomacy and global health, and working with a variety of both development and philanthropic institutions, including Ford and CDC. And a number of other places, and now with one of the very interesting, and Medtronic's a great company and doing some really incredible work in their philanthropic area. And then Raj Punjabi is the co-founder and CEO of Last Mile Health, and he's an associate physician at Harvard in the Division of Global Health Equity, and has done some remarkable things himself, even though I can't believe you've done all this when I look at you and think you're probably, just a really young guy, and just think of all the opportunities in the future.
A lot of hair.
Yeah. Well, you can't even go there with me. And he was named social disruptor by the Ford 400 Summit. So let's start with Ian and give us a perspective from the world that you've experienced.
Good morning. It is really a pleasure to be with you here this morning. And I suppose, given my last 8 months, it's a pleasure to be anywhere, but particularly on this stage and with the gravitas sitting next to me. I need to start with a caveat. I'm not a policymaker. I'm not a global health expert. I'm a clinician. My sort of sacred space is the bedside. But that space has changed a little bit in the past 7 or 8 months. And so I've begun to talk about this space as sort of an odd dual citizenship. I was born in Zimbabwe, and I'm a naturalized U.S. citizen, but not a citizenship that sort of is political, but one that kind of holds in tension these dual roles as Ebola doctor and Ebola patient. And it's easy to get lost in very intimidating statistics around this outbreak. And I hope, in a bilingual way, today I can sort of put some flesh and bone on some of those numbers. Before I begin, I need to sort of say something to this particular room as an Ebola patient. In September, I was medevaced to Emory, and within the first week, developed what we call multi-system organ failure. It's an ominous term, yeah? My lungs failed, and I needed mechanical ventilation for 2 weeks. My kidneys failed, and I needed dialysis for 3 weeks. I became delirious in the first week with a severe hemorrhagic encephalitis as Ebola trespassed in my brain. And I have to say that, given my experience in Sierra Leone, had I not been medevaced, I would have been dead in a week. So I have a particular personal and profound gratitude to those people and those organizations, and they're both public and private, that enabled me to be here today, right? There's no more relevant sort of philanthropy than Paul Allen's medevac plan. So Jane, thank you for the opportunity to be here and for the invitation to sit with this particular panel. Can I begin by just repeating a Ugandan proverb that I think lends something to our discussion? Yeah? This proverb is as follows. The hunter in pursuit of an elephant doesn't stop to throw stones at birds. Hunter in pursuit of an elephant doesn't stop to throw stones at birds. There are going to be many long-term lessons that Dr. Frieden has covered quite well as we sort of crunch the calculus of this outbreak. And I'd like to just tell you a few stories that shine a light on two of the important lessons that I don't want to get lost in the stone throwing that I think are particular elephants. So in August of last year, I was deployed by the World Health Organization to an Ebola treatment unit in Kenema, Sierra Leone. It was a very different Sierra Leone in August of 2014 than it is now. So there's obviously been a massive, much needed, though delayed, scale up. But in August of last year, Sierra Leone was a very different place. There are now, I think a month or two ago, over 20 ETUs operating in Sierra Leone. In August, there were 2. And for a time when the others shut down, we were the only ETU receiving patients. So Sierra Leone and Kenema in particular sat smack dab in the middle of the hot zone as the virus disrespected international borders, crossed the border from Guinea, and then began to, with an eye always to Freetown in the capital, began to take root and eventually to roar. So that was the landscape to which I went. We had 80 to 90 patients at any one time. Right? This with a small team of clinicians providing some clinical and technical expertise, but a much larger team of national staff. Right? And in that setting, people died. Sometimes 6, sometimes 8, even days with 10 patients a day. Right? And people survived, thousands of them, ultimately. In the middle of all of that, I worked with a group of national healthcare workers, and these were nurses, hygienists, lab technicians, who were understandably anxious about heading into isolation zones behind the curtain in which they had seen many of their colleagues die on a daily basis. Right? So in one regard, there was a really uncommon heroism that we don't talk about enough as they entered with very little fanfare. I'm a bit sheepish about the attention I get, but they'd been doing that daily and resolutely for months. So can I tell you a quick story, just a very quick one? Yeah. Yep. Let me tell you about Nancy Yoko. The name is important, Nancy Yoko. She was the head nurse at Kenema. She was tough, she was kind, and she sort of was the glue that kept together this group of understandably anxious healthcare workers. She was exhausted. And as September turned, she came to me with fever. We admitted her to our suspect unit, transferred her to the confirmed, and I cared for her as she deteriorated, and then mourned with the rest of my staff when she died. So Nancy was particularly capable, she was particularly available, and she was particularly willing. And I asked myself the same question, you know, this question actually, what is it about what got Nancy there for her to be in the right place at the right time in this outbreak? And I think as I wonder sort of if she hadn't been so exhausted, if she's had some people to share that burden with, maybe things had been different. It's easy to get lost in the abstract themes of health system strengthening. They're so important, but it's easy to get lost in them. And as we do, and we think about the systems and the stuff we need and the space we need, that a very crucial and missing element in this outbreak was the staff that we need. Yeah? So thinking about how we most effectively build and develop and mature a group of agile African talent is a very crucial piece in this, thinking about how we build, actually, not rebuild, we build. And so I think the first elephant that I'd like to talk about, and then maybe others will come up later, is that we will be in this place again, right? We will, whether it's a filovirus or MERS or a coronavirus or something new, we will be here again. And as we begin thinking in kind of Marshall Plan ways about big strategic themes, we must pay attention to how best to grow an agile group of local talent. And so that's, I think that's probably the most important elephant not to lose sight of.
Great, great. So Raj, you've seen this from a different angle, but from the front lines as well, and you're doing some very interesting thinking and work. Love to, why don't you share that with us and tell us what you think the big lessons, opportunities, and particularly for this audience, what they could be thinking about.
Sure. If you don't mind, I just wanted to start by thanking you, Ian, for being on the front lines of this. And if it's okay with everyone, I just know so many people have lost their lives in our countries, and there's still people fighting on the front lines. And if we could just take a moment of silence to honor the people that are still doing this, and many of you who've stood with them. Thanks. You know, this is deeply personal, not just for Ian, for many of us up here, for many of you who've been involved, but the assault of this virus in West Africa wasn't a regional phenomenon. This was an assault of a virus against all of us in humanity. For me, this obviously is linked. I grew up in Liberia. I was privileged to be born there. My parents immigrated from India. I lived there until I was 9, seeing the dead bodies on the streets that you see in Monrovia. That's where I had grown up. That place is an incredible place, filled with incredible leaders. And they made up that country in the 1980s. In 1990, a civil war erupted. Many of us lost our home, our way of living. Thousands of us fled. My first intersection with philanthropy was fleeing that war, ended up in Freetown in Sierra Leone, and then a family in North Carolina took my family in. I had a chance to, my family did, to get back on our feet. And I had a chance when I was about a decade ago, 24 years old with a lot more hair, to go back to Liberia. And 10 years ago I did, and what I found was just utter destruction. After 15 years of war, and it's important to understand the long history of this. These are interrelated battles. We may look at it as a construct of a virus, an epidemic, but this is also a battle of poor healthcare and really inequality. When I got back home, there are 51 doctors left to serve a country of 4 million people. What can you do with that talent? 51 doctors to serve 4 million people. It'd be like San Francisco having 8 physicians to serve in the entire city. You can't fight Ebola with that. You can't fight pneumonia, malaria with that. If you got sick in a city, you might stand a chance where those few doctors were, but you got sick in the remote villages where me and a number of our colleagues were working, in the rainforest, the same rainforest where this epidemic started, you would often die and die anonymously. If your 2-year-old boy gets a fever, you'd throw him on your back, get to the river, get in a canoe, paddle across, and walk for up to 2 days just to get a diagnosis for a fever. It turned out that there's 1 billion people on this planet living this way, and one of those 1 billion people was a little boy named Emil, who lived in the same rainforest we work in across the border in southern Guinea, who came down as a 2-year-old with fever, vomiting, and diarrhea about 16, 17 months ago in December of 2013. He would die of those symptoms in a little village of about 300 people, 31 houses. His mother would die after trying to care for him. His grandmother would die. Sisters would die. It would spread from one village to another where there's not existing health workers, there's not existing primary care in the remote rainforest regions of 1 country to 3. It wasn't until 3 months after that little boy died before, as Tom said, the public health system recognized that this was Ebola and started to respond. By then it had gone from 3 countries to eventually go to 7, from remote villages to capital cities. It closed bowling alleys in New York, closed schools in Dallas. Billions of dollars would be spent on this. Billions of dollars are still being spent on this to chase it. And it all started with this one little boy in a rainforest village who didn't have real health care available to him. These epidemics are incidents built on top of inequalities that have already existed. 1 billion people live this way in rainforests and mountains and deserts. If Ebola anywhere is a threat to people everywhere, then part of the answer has to be getting a health worker for anyone, anywhere, and making sure the entire things that health worker needs, the equipment, the stuff, the clinics to refer to, are important. A few of you we've worked together during this crisis, and I know we're still learning lots of lessons, but getting a health worker for anyone, anywhere is really the essence of, and the perspective that we bring to this as last mile health. Last mile, of course, being those last mile villages. Our entire focus before this crisis, we were founded by village health workers in these remote villages 8 years ago, was to create a workforce of local village health workers by professionalizing those workers. So giving health workers in remote villages the tools, the training, the coaching from a nurse, the payment, the employment. Most of these workers never get paid to do their work, to save lives in the world's most remote villages. When this crisis hit us, in March of last year, it entered Liberia. Our workers sprang into action, these so-called village-based frontline health workers. In October of this past year, I was there with Lorenzo, a physician assistant who coaches these workers. He's a fellow Liberian who'd left during the war, came back, was training a bunch of these workers. A woman had come from Monrovia with Ebola, and like many of us who get afraid, we want to go to our families. She was too afraid to go to a treatment unit. She went from Monrovia to her family, which lived 10 hours into the jungle in the rainforest. She died amongst her family 10 months into the crisis in this remote area. People had heard about Ebola. They hadn't heard the basic message that safe burials were critical. So they did what any of us would want to do when we lose a loved one. We'd bury her. They buried her. 14 days later, 14 people had died, 90 people had been infected, hundreds of people had been exposed, hundreds more were at risk, and they don't have a bridge to get to them. There's no way a Jeep can get over there. They don't have a mobile phone to contact. Somebody had walked the message over to the public health authorities. The CDC, MSF, Last Mile Health, Partners in Health, UCSF, a number of you behind this, the government of Liberia and the lead try to respond to this. They trained 1,300 health workers, traditional healers, village-based workers, got lab samples from people in the villages, blood samples, got the ones who were sick to care, tracked the ones who were actually at risk of getting sick in the following 21 days, and made sure that those that hadn't been exposed didn't get exposed. The ones we finally reached, and Tom made a great point about speed, 75% of them survived. Those workers now are continuing to provide primary health care. And that's the second point I want to make, and I'll turn it back over to you, is that these frontline health workers in the villages, local talent, weren't only important to respond, they're important to keep healthcare going. Across our country, 60% of clinic visits completely stopped. The safe delivery rate, the non-Ebola deaths from this were probably just as significant, but perhaps not as dramatized and dramatic as the Ebola deaths. The number of mothers across the country that got safe deliveries plummeted threefold. In places that we had already been working in partnership with the government, 80% continued to get health care. 6,000 kids continue to get treatment for malaria, diarrhea, and pneumonia because a nurse, a local talented person, decided that we weren't going to stop providing care with community health workers. We knew these community health workers could do better. We coached them on a different protocol, realized that we stopped treating kids for any cause of fever because we were scared of Ebola, that more kids would die from malaria, pneumonia, and diarrhea than Ebola itself. And they kept those 6,000 kids. Not a single day of treatment was missed. And the last thing is that these workers now have the opportunity to rebuild and build back the country and provide health care. But we have to be committed as a philanthropic community, as a social impact community, to three things: supporting those kinds of workers, the kind of talent that Ian spoke about, holding us accountable to covering each and every single person in these countries. There's an opportunity right now to transform the way these countries provide healthcare at a time that matters most, not just for our three countries, but I think we'd all argue for the world itself. And I hope we're going to have philanthropists in this room who've been with us and others continue to push the groups with their funding, but also with their advocacy to stay accountable to that vision of getting healthcare to anyone, no matter where they live.
Great, fantastic, and really kudos on your big work. So from the perspective of a clinician and patient to more systemic, how do we work on the ground? How do we train? How do we think about those issues to, Jacob, you're looking at it from a slightly different aperture through, around broader systemic changes as well. Can you tell us a little bit what you're thinking and thoughts on Tom's comments?
Sure, no, thanks, I appreciate it, and good morning to everybody. So before I do, I just have to I always have to tell a Caribbean story, right? So there was a doctor who, a person who went to the doctor because he was having eye vision problems. He says, doctor, I get in double vision. And the doctor says, well, close one eye, boy, close one eye. And so, I think that one of the things that I really greatly appreciate sitting where I'm sitting right now is to be between two amazing people from the front line. Ian, who represents not only a clinician who really cares and gives, but somebody who yourself is living with and has lived with the very disease and epidemic we're talking about. And coming from a philanthropy and a company that really believes that patients come first and the voice of the patient is the most powerful, I appreciate, I commend you, I respect you for the words that you shared with us. And I think likewise to my right with Raj, who really represents the people who are on the front line, are putting themselves on the line, using their expertise, their knowledge and ability to make a difference. Frontline health workers is the answer to really being able to solve many of the things that you talked about. I want to thank you. And Last Mile Health has been a partner of ours even before we began to deal with the issue of Ebola. So I have the fun opportunity of representing both the corporate side as well as philanthropy by leading the corporate philanthropy for a company like Medtronic. So you think about, why is Medtronic a non-communicable disease, chronic disease-focused, debilitative disease-focused company focused on Ebola? Well, when we talk about the fact that our technologies and our solutions impact one individual somewhere in the world every 3 seconds, we realize that once we've invested in individuals, we have a continual investment to ensure that they are able to do what our co-founder talks a lot about, and that is live that extra life that's been given to them. And Ian, I think of the conversation you talked about in terms of being someone who has survived it. What is the reason and what is the purpose? You've been given extra life. And the extra life's not just for yourself, but it's about being able to use that extra life to make a difference for other people as well. And so, you know, the challenge that we have is really almost a two-vision challenge focused on the same issue. On one level, we all collectively in this room have an opportunity to make a difference in parts of the world that have not been able to do it on their own thus far. Actually, none of us have done it on our own, right? And so to be able to collaborate around the issues, the dire issues, today, Ebola, tomorrow, whatever the challenge might be, ultimately in the long run to build that health system that enables us to respond to healthcare needs on a day-to-day basis, as Tom was just talking about. That's an opportunity for us collectively to use our time, our talents, and our treasures to make a difference on a global level. On the other side as well, I think the other side of the double vision is a recognition of the fact that we are a global community. And those of us who were born to the South yesterday, who may be leaders and partners in the North today, we realize that, you know, you never know where you're going to be. We're a connected planet. And so what does happen in Monrovia, what does happen in other parts of West Africa and other parts of the world have direct impacts here. So, little Minnesota-based company, why would Medtronic care? We sit in the middle of one of the largest Liberian diasporas in the world, Minneapolis, Minnesota, that has 2 generations now of Liberian community members who are still very, very much linked to their West African roots and West African families and communities. The challenge we see is not only being able to provide the technology, the innovation, the engagement we can as an innovation company for healthcare, but how do we as a good neighbor prepare our hometown community for being able to deal with the aftermath and the issues around Ebola? We have children arriving who no longer have parents in Liberia, but they have cousins and grandparents in Minnesota who are dealing with the stigma, the discrimination, the post-traumatic syndrome issues related to a situation like Ebola. There is a wide range of needs and concerns directly in terms of clinical care, but we also have to recognize that to be able to heal the world, we also look at the implications on a societal, political, economic, and just a personal level. We all have a role that we can play. I'm so glad that Tom always reminds us of find, stop, and prevent, because those 3 are very important parts of our public health response to Ebola or to any public health issue. The 4th one I always add is heal. And whether we're talking about being able to heal a medical problem, the actual physiologic condition, or whether we heal our societies and the way that we come together and work together to be able to bring us back to the global realities of diversity, engagement, and interaction, Ebola is going to give us many opportunities to learn how we, as a human population, care for each other and ultimately care for ourselves.
That's great. Thank you, Jacob. So I have the challenging job of both being the moderator, I'm supposed to be a speaker, and the timekeeper, so I'm trying to keep all those in balance. But let me speak quickly from another point of view on this challenge, and it's a point of view only informed and enabled by frontline viewpoints from folks at the bedside, from the communities we work in around the world, but it is the role of innovation in this work, because one of the worries is that we've got to rethink, rebuild, reshape in order to actually enable those communities and the workers and and the communities to come together, but we have to help them, work with them with better ways to go about doing this. So, and better evidenced ways to, we learn and relearn how to do things, and we're not actually sharing that operational research and that sort of that learning. And I think this is also a time for us to bring that forward. We also know that there's going to be a demand for new tools. And we think about that often in the way about, okay, we need a new vaccine or a new drug. And yeah, those are very important. And we, PATH works on some of the most significant tools in the vaccine and drug space in the global health. But what I think we are sometimes forgetting about is the innovation and tools that would actually be a game changer in a rural village in Liberia. And so let me give you an example of the challenge we face, is that we need to reshape, to build these systems to have that kind of, everybody merits, deserves, and should have a health worker to make sure they're there. But it could take us multiple generations to do that. That worries me. That isn't okay. So how do we then think about innovation to say, well, maybe we have to make that look different tomorrow than the way that looked yesterday in these villages. So instead of a trained worker needing to have a certain set of protocols in order to be able to deliver a certain set of tools, maybe we can innovate to make sure that they can actually do things simpler, easier, quicker, and you don't have to have as much training. So we're actually quite concerned about this idea of what is often called task shifting. So can we shift the tasks more and more broadly in a non-emergent situation? I think in an emergency situation, the rules of tasks are, all go to hell. I mean, everybody's doing whatever they can to get through. But actually, to make sure that there is there are actually simple to use devices that actually can be used without a whole lot of training. So let me give you a very quick example. It's not it came out of the vaccine space, but it's actually in a family planning example. But so one of the challenges we have is it's quite difficult for a fairly untrained person to figure out how to use a syringe, fill a needle, make sure the bubble's out, to give a proper vaccine. So the immunization processes actually take some training. So then that's a challenge, because it means there's just limited bandwidth for what people can do. So we've started thinking, well, maybe we could make that simpler. So long story short is came up with a small packaged plastic pre-filled package that is already pre-filled, and all it has is you just have to go like that, and you squeeze it, and it's done. And you've given the vaccine, and it doesn't take a trained health worker to do that. So then we started thinking, wow, that's actually really great. We're seeing that uptake. We're seeing actually moving the training to a different level in order to enable more people to do the job. So then we started thinking, okay, we have this huge problem in the family planning area with unmet need of women who want contraceptives but don't have access. And so why not, the preferred access in a lot of places that we work is injectables, because they're long lasting, they're hidden, so they don't have to get permission and navigate permission from their partner who might not provide that permission. So that's a preferred method. But how could we make that simpler? So we've actually taken that same package to figure out, now could we fill that with an injectable contraceptive, distribute that, and the game changer here is that women can eventually inject themselves. They don't have to go get permission to go to a clinic, go to a doctor, and we're working on that journey. And this is sort of the journey of innovation that has to actually start with what those women are asking for in the community and what the capabilities we actually have in the community to deliver, which are limited in many places. And then sort of reverse engineering that thinking backwards and say, okay, well, if that's the case, can we make that tool better? Can we make it simpler? Can we really listen to what people are telling us to do? So I think there is an important conversation at three levels going on right now. One is the large, what do we do with the billions of dollars allocation, and what are the big levers, and how should we reform the WHO, and all of the different things about how to turn this so-called Ebola moment into, a real reform agenda. There's a second, which is, how do we actually really finally grasp what we have to do at the village and the community and at the frontline level. What is it to enable your vision of everyone having a health worker? And that really is it's going to be driven by people on the ground, national agendas. It's not, I mean, it's all, the globe's to solve, but that's going to be solved in country and subnational levels at some level. And then there's this third piece, is how do we help support those people to innovate either operational approaches, tools and devices, better data systems, and really provide better tools and models for them. So I think that's also going to be a critical piece. So I'm going to now go to the fairy godmother piece of this, which is you each have the same wand I gave to Tom. And very quickly, because I want to open up a couple questions, if you had that wand to do one big disruptive thing in this Ebola moment, and something that's like big and audacious but also doable, what would it be, Ian?
So I mentioned the first elephant. The second one for me is Jacob has talked about the relevance of what's happening in West Africa for our side of the pond, and I want to talk about a different direction. There's an emerging post-Ebola syndrome that's happening in survivors, and I've sort of become the poster child for that syndrome. In one sense, an unintended consequence of something very dear to me, my ability to access that care, is that we've been able to sort of intersect, to use a Paul Farmerism, modern medicine with Ebola in ways that we never have been able to before, right? Let me give you a very quick example. In October, in the same place that I cared for patients, they began to ask those patients, what are you suffering from? And people said, terrible fatigue, inflammatory joint pain and arthritis, insomnia, and 40% of them complain of eye signs and symptoms. In December, I went blind in my left eye. I developed a very acute, aggressive inflammatory process that really, once it was unleashed, took 3 weeks until I couldn't see my hand right in front of my eye. And I met Steve Ye, who's an infectious uveitis. Uveitis is the medical speak for that inflammation. And he spent the next weeks peering into my eye, but unable to see the back of my eye, the retina, through this dense inflammatory debris and obstruction. From the other side of the theater, I was looking from the same retina and couldn't see out to the world. Very rapidly, he became the world's expert in what is essentially a new disease process. We had a little noise, a little signal in the mid-90s of 4 patients with very mild similar disease, but nothing like mine. Last week, Steve Ye and two docs from the Emory Eye team and myself were in Monrovia, invited by the ELWA hospital to do 3 things. Number 1, to provide patient care, and that's important. This has to be driven by delivering care to patients. Number 2, to build capacity in mid-level providers to examine eyes, to triage eyes, to decide who needs an ophthalmologist. And then in doctors, we took portable slit lamps and left them in situ and trained them. And then third, began to understand this disease process for the first time through a state-of-the-art microscope, right? That required an agility and a nimbleness that is very different from sometimes the slow, plodding ways Global North scholarship makes a difference on the ground on the other side. And so particularly in speaking to this room, I think you have you're uniquely poised to enable that type of agility and nimbleness in getting what we learn from medically evacuated survivors, and then those same principles unpacked in situ on the ground to make a difference and to save African eyes. You can imagine someone survives their first death, right? These patients have been through hell at home first, and then in an ETU, a very lonelier hell. But as they've survived that first death, you can imagine the tragedy of, in a sense, what is a second death? It's not so far below dying in West Africa. That is going to require a very quick and agile and nimble effort that I think the people in this room are in a particular have a particular ability to enable. And so the second elephant is that. I'm sorry, that's a windy answer, but.
Jacob, you've got the wand.
Okay, so I have the wand, and I think probably the first stroke of the wand, I believe the wand has a couple.
Oh, you're cheating. Right? I can see it coming.
Okay, one stroke.
Okay.
So for me, I think I would really wish, given the fact that the largest healthcare workforce is the family caregiver around the world, More caregivers come from the household of the individual in need, and oftentimes we neglect the caregiver herself as well. Some way to be able to strengthen that caregiver network with support from those of us who are around her. It's interesting to know that we can make a world of a difference in health if each of us were trained in first aid, CPR, washing hands, basic things like that. So my wand would be used somehow or another to be able to get the entire world to understand the germ theory and believe in it, and then take the smallest steps in being able to equip oneself to be able to care for the person to your left and your right in any normal day-to-day circumstance.
A fantastic idea. Yeah, no, great. Okay, it's yours, Raj.
Mine builds on Jacob's. I think, professionalizing local caregiving, giving the village health workers the equipment, the tools that you spoke of, the employment in particular, and the coaching that they need to get healthcare for anyone, anywhere is really the challenge. And I would say speed. Everyone in this room that's been involved in this, or those that want to still be involved, has an opportunity to do it in any one of these 3 countries. But the president of Liberia, along with the presidents of the other 2 countries, have just said that expanding rural coverage through community health workers is the #1 priority. Liberia has a plan, the government does, for 4,000 of these workers to be put in for the 1.5 million people who have no physical access to care in the next 7 years. They need help to do that. The World Bank, USAID, the US Congress may be putting funding in, but there is a role for helping these governments build the capacity to actually win that funding. There's a role for making sure they can accelerate the launch of these programs, and there's a role for making them innovative, and anyone in this room can make a difference in that. And I would hope that we act with the speed and urgency and honor the people who've been affected by this.
I want to make a comment, not take the wand, but one point that I think it's important to understand, that when we talk, a verb you used about employment, when we talk about community healthcare workers around much of the continent of Africa, now it varies by country and subnational region, but many, if not most, are not paid. So I think people think, oh, there's this workforce out there. This is not a workforce the way we think of a workforce. This is a set of community volunteers, and that's an important distinction. So we have a few minutes, very few minutes, but if there's a couple of questions from the audience, be glad to serve. The one in the back, yeah. We're gonna have to go quick, unfortunately, because this thing is beeping.
Steve Alderman from the Peter C. Alderman Foundation. Terrific panel. Raj, the idea of professionalizing a community health workforce is amazing, but the process has been front-loaded, training. Right. Would you mind commenting on the place for supervision and the place for self-care, so that once training these people, we don't lose this valuable force?
Yeah, thank you. We do 90% of the training in this program that the government now has, built off of the experience from Ebola. 90% of the training is done actually in the village level, at the bedside, with nurses and physician assistants coaching these village health workers to do it. I think, we always knew that was important because you diagnose a child with pneumonia, you can't solve it all in the community. You might be able to treat the kids with non-severe pneumonia, but there's some kids that need to get hospitalized. And the community health worker, if we truly believe in their value and what they could bring, should be able to teach them how to differentiate between the two and get the kid to care if it needs it. Turned out during this crisis that became essential. A nurse named Alice Johnson, who you've met, Steve, from Liberia, who coaches these workers. It's the coolest nurse job in the world. You get out on a motorbike 50 miles a week, and you're out there coaching these workers in the villages where healthcare had never been before. When all the community health workers in other parts of the country and other parts of other countries stopped working because they felt they were too unsafe to give care, they stopped providing care for kids with children with fever, malaria, pneumonia, diarrhea, because they were afraid those health workers might not know the difference between fever with malaria and fever with Ebola. They could get sick, the health worker would die. This nurse said, I'm not going to fault of that. I know these workers can be coached. I've seen them do everything from diagnosing pneumonia to malaria to doing, I got my blood pressure taken there 2 weeks ago. If they can do that, they can figure out the difference here, and if they're provided safe care, if they're provided safety, it can happen. That simple idea, based on a training program based on the home, allowed 6,000 kids to get treated from deadly illnesses during this crisis.
Yes, oh, I'm sorry, I might have missed a, but we don't have much time, actually. I'm not sure, it's going up instead of down.
I'm Susan from BRAC, and we also have been working in Liberia and Sierra Leone. I just wanted to link this incredibly moving, brilliant panel to where we started with also disaster crisis, the resilience conversation. And part of, Steve, your point about a lot of the community health workers being unpaid, and Jacob, your point about it's that woman in the household, the caregivers. I mean, female work subsidizes the care economy. And one of the ways that we've been trying to say, all right, we're using these volunteer, self-employed community health workers, but they also need access to livelihood support. So hand in glove, the role of microfinance and ability for livelihood support for everybody to have decent work, and that capacity is part of it. So the plea is for us to look at the health system in the widest context, with where we look at a 10-year vision of a different kind of West Africa there. And I just met with this incredible young man who's not here right now. He ran out somewhere, but he
knew you were going to point him out.
He is the country director who must be too shy of the Liberia Young Professionals Program. And I think there's a huge opportunity, talk to Yvonne from Disney, for us to invest in a leapfrog strategy for this local talent issue. Anyway. Thank you. You were great.
Jacob, did you want to?
Yeah, so one of the things I wanted to say, thanks for that comment, and I think that's one of the roles of philanthropy, sometimes being able to ignite opportunity can really play an instrumental role. One of the enjoyments of being from a corporate philanthropy side as well is that I think an effective business models can help to drive sustainability once we've ignited and proven a process. So we're looking at ways of being able to develop sustainable capacity of community health workers to continue to serve, but to have some kind of a driving business model that can help feed the need for funding of such.
So we've reached the end of our time, unfortunately, but I do want to challenge the group, both on the stage and in the room, that the real question will be in 5 years from now, will we look back at the Ebola moment as just, okay, happened, went, we spent a lot of money, number of people died, and we moved on? Or is it an opportunity, as I think there's some energy not only in this room, but frankly at the global stage and in a lot of corners, to say, wow, we just learned something pretty profound and tragic, and to underscore the tragedy, to remind everyone, and I find myself in front of policymakers doing this constantly, that the number of people that died is dwarfed by the number of people who died of Ebola. The rates of unattended birth, therefore infant deaths, the rates of pneumonia, diarrhea, malaria that have not been attended, and now we're seeing just enormous impact, and that has a long-term implication. So the question then becomes, are we actually going to get our act together and actually transform some of the issues in the global health government structure? Are we going to actually take the moment to figure out better approaches to train communities? Can we actually get more insight into the better innovation models for products and services? And I think it's a collective obligation for all of us to take this moment and back to honoring those who either have lost their lives or have actually suffered enormously under this, to honor them by making sure we do turn this into a real moment of change. So with that, thank you all, thank the panel, and please stay. There's another panel coming.